I appreciate the introduction. And that covered a lot of my background very concisely. And I will say that one of the projects I'll be speaking about today is at this intersection of understanding complex social processes like stigma and discrimination that affect health outcomes and that also tend to affect policy processes. And so I'll hopefully be able to show you some of those connections as I talk. But one of my areas of focus academically has been in stigma theory and measurement, understanding it as a social phenomenon that creates a lot of harm in the world. It is relatively tricky to measure, but that's one of the main goals of many of my NGO partners in their advocacy work that they do, is that they see much of their work as being about sensitization, minimizing stigma, reducing discrimination and advancing rights. So I'm going to talk a bit about some of our measurement and scholarly activities, but also some of the practical on the ground work that my NGO partners have been doing, putting advocacy into practice to advance health rights in Kilifi County in Kenya. So I met my NGO partners at Kupenda and Kuhenza for the Children. It's a partnership, a partner organization that Kupenda for the Children is registered in the United States. Kuhenza for the Children is registered in Kilifi County, Kenya. Both of them work very closely together around transforming harmful beliefs about disability, working in many sectors. So they work in education and they work in like jobs and skill development. They also work in the health sector. So with my background, I've been working with them primarily in their activities related to healthcare access and health system strengthening for people with disabilities in the county. But they do a lot of different types of work and advocacy. And I invited them to join us today. So if I see them come into the Zoom meeting, I might, include them in some of our discussions, or especially if you have specific questions about their advocacy strategies and models, I will probably let them answer those questions for me. But they've been working for over 25 years. I will go over a bit about their sort of model and approach a little bit later in the presentation. But they have a really strong and long-term vision of helping to create a society that's fully integrated, where people of all abilities have access to key services and are included in a loving community. So they have a really strong and clear principles around inclusion and justice. So in case they do end up popping in on the call, I just wanted to quickly introduce who they are, so that if I call on them later, you know who I'm talking about. Leonard Mbanani is the executive director of Kuhenza for the Children in their Kenya office. He is also a co-founder, along with Cynthia Bauer, who's the head of the US office. And a couple of their other staff might be joining. And just so that everybody has access to their information, I included their organizational website on this slide, because they do have really good videos that demonstrate some of the work that they're doing. They have toolkits and guides for how to do advocacy with certain populations. They have a lot of really amazing resources on their website that might be generally of interest to folks. And I think they also have a couple of our reports. So I'm going to kind of gloss over some of our data and research, but they have some more detailed information about some of the projects we've done together on their website as well. So from my role with my research, one of the things I was mentioning is that stigma as a social process, I think a lot of people are very much aware of what stigma is, that we often see it in communities that are marginalized. It is relatively more complex if you're trying to think about how do we measure it? How do we know like how much stigma is present or what kind of stigma is present? And that sort of knowledge can be very useful for advocates. Most of the research on stigma comes out of the HIV/AIDS community. That's where a lot of attention to stigma related to health concerns first originated. That's also what my background is. I spent a lot of my 20s and 30s working on HIV and family planning and reproductive and sexual health issues. And so that's how I became introduced to this area of stigma research. One of the areas where stigma research is growing is in mental health, but there still has not been a ton of work done looking at how to measure disability-related stigma. So some of the goals of the work we've been doing is figuring out, how do we take these validated scales and make them appropriate and adapt them in important ways for different conditions besides HIV and mental health, but also to really specific cultural environments and potentially different populations of people that Kupenda and Kuhenza work with. With the validated scales that exist, they do require a lot of adaptation. And so part of what we're doing is we're trying to figure out how to do this well. So some of the data I'll go over today shows that we're testing some stuff and some things are working and some things aren't. But we've been learning a lot along the way. And what we're also really trying to understand more clearly is how to use stigma theory that it gives us a lot more insight into what causes stigma. And some of what I know from stigma theory is not yet really made it into stigma measurement. And so we're also trying to be innovative and to be more theoretically robust in how we go about measuring stigma. So I'll explain this more in just a second. But what we've also noticed in the academic literature is that oftentimes, people who are working on stigma are only working on either populations of people who are maybe considered the stigmatizers, those who are spreading stigmatizing beliefs, those who are in positions of power that might be able to harm marginalized populations, or on the flip side, working with marginalized groups to understand internalized stigma and how to mitigate that. But Kuhenza and Kupenda, they're really doing both at the same time. So we're getting data from both people who are in positions of power, who might be spreading stigmatizing beliefs, but also from the affected groups, people with disabilities, people who might be experiencing discrimination, internalized stigma. And we're getting data from both people at the same time. And so I think that's also allowing us to see if the advocacy work that Kuhenza is doing, what sorts of effects it's having. Is it making people's lives better? Is it changing harmful beliefs? Is it having an effect on internalized stigma as well? So we've been tackling this issue basically across all groups involved in this more complicated social process. I'm just going to back up a little bit so I can talk a bit about stigma theory and what it is and how we've been studying this. As I think most people know, stigma is a process of attaching a negative label to a behavior, to a person, to a group of people. And it's not an inherent attribute of people or of certain actions, but it's something that somebody else puts on from the outside. We make a judgment about somebody and we place a negative label on them. And this often then leads to things like discrimination or status loss. And sometimes it can lead to things like abuse and violence and other forms of harm. What came out of early HIV research on stigma that I think is really important and has still not been sort of fully adopted amongst stigma research is that this early paper that I have cited here in 1998 found that stigma comes from different places. It's often comes from strong emotional reactions that people have in the face of something that's different. And so they've classified stigma according to these two different categories: instrumental stigma and symbolic stigma. Instrumental stigma often comes from fear. It's this idea that we see something that's unfamiliar, we see something that we might think of as scary, we are afraid of it, and so we ostracize a person for that reason, or we socially distance ourselves from a person for that reason. So in the context of HIV, and this is similar with a lot of, say, infectious diseases, that infectious disease comes with a perceived threat, that sometimes there might be a good reason to be afraid of an infectious disease, but then often what we end up doing is putting negative labels on people and ostracizing them because of their condition. Symbolic stigma, on the other hand, is a little bit different. It's not fear-based, it's based on this idea of harsh moral judgment. And so sometimes there are emotional roots. It could be like feelings of like disgust or distrust, condemnation. So we often are seeing, certain behaviors, say if it's like sexual behavior, drug use, that we see as like morally bad, and that we label those negatively. And then we also then label people negatively. And so there's a different root cause of this form of stigma. And so in early HIV work, what some advocates realized is that, if we just treat stigma as if it's only one thing, and so early advocates were like, well, if we just give people more information about HIV, we'll reduce stigma. So they did some interventions where they presented a lot of information on where HIV comes from, explaining that it's actually, you cannot get it from sharing a meal with somebody. You cannot get HIV from sharing a restroom. It requires only a couple like specific types of acts to get HIV. They found that fear went down, but harsh moral judgment went up. That in hearing that, people began to think, oh, well, HIV is actually really hard to get. So if you get it, you must be doing very bad things. So sometimes when it comes to how we intervene, if we're not paying attention to both, we might accidentally make one worse. So these ideas have been really important to me in my work and understanding how to understand stigma related to health issues. So part of what I've also been doing is trying to take some of these ways of measuring and making these distinctions more clear. One of the shortcomings being that early survey research didn't do a good job of distinguishing between these two different types of stigma. So I just wanted to give you some examples of how stigma is often measured. A lot of questions on surveys do try to get at some of these underlying emotional reactions that people have. So it could be things about, feelings of discomfort, whether or not people see people with HIV or people with disability as similar to themselves or as very different. And that can be part of this process of othering. So social distance measures, thinking about people's capabilities, and whether or not we judge them harshly for what they can or cannot do. And then we also often ask questions about behaviors or intentional behaviors. One of the issues that I've had with questions like this, and that Kupenda and Kuenza and I have talked about a lot, is that some of these questions are really general and they don't really let you know if it's fear-based or if it's moral judgment-based. So part of what we've also been doing is trying to come up with more specific questions that help us get at those important distinctions and types of stigma. So some of the newer measures we've been using in some survey research try to do this more clearly, distinguishing between fear and moral judgment. We've also found over time that asking people about behaviors that they take or behavioral intentions, we often get a lot of very inaccurate answers. And we know this because, for example, with one of our newer projects, we're working in the health system with community health promoters and nurses. We have a lot of reports from children with disabilities and their families that they are not treated very kindly when they go in for medical care. And so when we ask nurses, how do you treat children with disabilities? Nurses will tell us one thing, and then we hear completely different things from the children that we also survey and interview. So we've started to kind of drop some of these behavioral intention questions. And this, I think, just gets at one of the difficulties of stigma research is that people often know that you want to hear certain things. And so it can be difficult to get truthful responses to questions. And this is why we have found it really important to have data coming from multiple sources, to be talking to people with disabilities and their families, as well as some of the other groups that Kuenza and Kupenda have been targeting with interventions, so that we can get a better picture of what's actually happening. And this is also where qualitative methods can be more useful and more participatory observational work. for this talk, I'm kind of focusing on our survey work, but we've also found, again, that there are some definite challenges in trying to ask people questions on surveys about stigma beliefs and practices. All right, so that's the sort of theoretical academic overview. And now I'm going to get into sort of the more practical pieces of what we've been doing together to better understand disability-related stigma, to address it in communities, and to help advance health rights. So from the very beginning, we all recognize that there are a lot of challenges in doing this work. Like in many places, there's not strong prevalence data on just how common certain disabilities are. This has been a challenge for Kuhenza and Kupenda as advocates, because they often are told by people in the community that, you know, we just don't have that many people with disabilities. Like, this just does not seem to be an important or pressing problem. And so having more data on just how many children there are with disabilities, how common certain disabilities are, that becomes an important advocacy tool for them. In some ways too, we always have this saying in sort of monitoring and evaluation that, like, you measure what's important. And so if we're not actually measuring prevalence, if we're not tracking people, I think that also leads to their neglect. So it's like they end up being ignored or forgotten by policymakers or people in charge. So one of the areas that Kuhenza has been working on is they've developed a case management app that helps them track children with disabilities in their county and the families that are taking care of them. And we've been using this not necessarily to create prevalence data, but to create GIS maps of households to try to get a sense of where people are, how common certain conditions are, but also where there are infrastructure or service gaps, where there are insufficient health facilities, insufficient schools, things of that nature. With Kupenda and Kuhenza's advocacy work, they've been working, like I mentioned, for several decades and have an extremely strong theory of change. They have very well-developed advocacy models and intervention strategies, but really needed to develop tools and systems for how to measure their impact. And that's where I came in partnership with them, is figuring out, how do we measure the impact? How do we therefore measure stigma? How do we measure if stigma is becoming less, and in what ways, on the basis of your advocacy work? And so this is the basic framework for all of the work that we've been doing together. So to cover a bit of their program model, and again, I'll refer you to their website for specific guidance that they have on how to do different types of advocacy and work with different groups of people. And just to give you some of their background, you know, they've done a lot of work with different community leaders, with local chiefs, traditional healers, pastors. Now we're working with community health promoters and nurses. And so they have different types of trainings and interventions for different groups. So they have a really robust method of training and doing sensitization in a way to reduce stigma. They also hold a lot of different types of events to raise awareness around disability, and a lot of these are mentioned on their website. And some of the specific strategies that they use, these are my more like academic names and descriptions for what they do. They would probably describe these differently from me. But typically in their trainings, they are very conscientious about addressing common harmful beliefs in the community and giving different explanations around, for example, where disabilities come from. In Kalihi County, there's a lot of sort of common thought that disabilities are caused by curses, witchcraft, punishments for sins. So in directly addressing these beliefs, they have to do this very carefully. And so if they're working with pastors, if they're working with traditional healers, they do talk about disabilities and these issues in different ways. And that's where framing becomes important. They also do a lot of what scholars in sort of intergroup conflict would refer to as intergroup contact theory. The idea being that maybe some of the discomfort around disability comes from limited interactions with people with disabilities. And so at many of their trainings, they will invite community members or their own staff or team members who have disabilities to come be a part of the trainings to answer questions, and to also demonstrate many of their capabilities physically to people in these groups to help reduce that lack of knowledge or lack of experience. And so they use a lot of intergroup contact theory in their interventions. They also do a lot of work to build empathy and understanding. That's what is meant by perspective taking. And they have their training model is such that it ends up becoming over time like almost like a train the trainers model. Well, they'll work with a group of traditional healers. Those traditional healers themselves become disability rights activists. They then go out into the community and conduct trainings of their own. And so the training model spreads out. So this in-group descriptive norm setting, it's basically when you have a traditional healer who's become a disability rights activist, they then become the session facilitator. They talk to other traditional healers. And that has been very effective at extending the disability rights work throughout the county that they're working in. So again, for more specific information on how they do this, I definitely recommend going to their website. So one of the first projects that we worked on together was with their traditional healer trainings. We decided to test out some new Stigma survey questions around the trainings that they had planned. And this was to help get better and stronger data on the impact of these trainings on stigmatizing beliefs. So we set this up initially as a quasi-field experiment. We did this to strengthen our ability to determine the impact of the intervention. Quasi-field experiments are not used a lot by organizations running programs. I think typically we see more of like a pre-test, post-test model around interventions, and we do some of that work too. But we wanted to try to do a quasi-field experiment here to better determine impact and to try to get better and more robust data over time. So Cuhenza recruited 2 different groups of traditional healers within Kalihi County. The way that we structured it is that the intervention group was surveyed, received the training, had a sort of post-test survey. The non-intervention group was surveyed initially and was scheduled to get the intervention 6 months later, and then we were going to follow both of these groups for 6 months. You can see on this timeline that when we started, we did not realize we were about to head into a global pandemic. So when the pandemic hit, we were not able to get our 3 and 6 month follow-up data, but we were able to get this comparison data around their intervention for the sort of immediate or short-term impact of it. Just to show you some of the stigma concepts we were looking at, the type of questions we asked related to it. We used a 5-point scale on these questions. I'm happy to spend more time chatting about this in Q&A if you have more specific survey-based questions. And we generally found that their trainings had a positive impact on stigma beliefs, that people became much more favorable towards disability at the end of their training. We also found that these questions in the middle of the slide did not work. They were not significant. We had enough traditional healers refuse to answer them that we can't really interpret them. And so that was our sign that these questions we'd been designing just were not effective questions. And so this has been part of our learning process, again, in figuring out how to measure stigma appropriately. So we found, some pretty important changes in beliefs, that a lot of beliefs around sort of equity and fairness and care for people with disabilities were already high, but got, significantly higher at the end of the training. We also found that some of the questions around common stereotypes, which people came at with sort of like worse levels of stigma, were the most improved over the course of the training. So just showing again that their model of intervention did have an impact on stigma beliefs. We also asked the traditional healers to list different causes of disability, and we left it really open. Our data collectors would just basically check off what traditional healers would report. So we asked them here kind of generally about, how is disability caused? Then we also asked them about specific conditions, both before and after the training. And we found that, before the training, most traditional healers were listing spiritual causes of disability, things like curses and witchcraft. And after the intervention, we're more likely to list things like infectious disease, prolonged and obstructed labor. Interestingly, they did continue to list many of the spiritual causes at the end of the training too. So what we saw traditional healers doing was layering some of their traditional beliefs with some of the more biomedical explanations for disability causation. So this was one where I really wanted to see how this changed over time. And unfortunately, we were not able to get any of our follow-up data because I was just really curious to see what happened to traditional beliefs over extended periods of time, or if it even mattered if those beliefs went away, as long as traditional healers were working to refer children to healthcare for certain conditions, and were working to, increase inclusion and love and community respect in their villages. So we found that, again, stigmatizing and discriminatory beliefs went down post-intervention. That we found, again, that sort of knowledge of disability causation improved, but we unfortunately can't answer some of these other questions about, did these changes last? Did things get better? Did it get worse? Did it stay the same? We honestly don't know. I think with Quissel's work, they often don't say just have a training and then leave. They continue to work with the groups that they train over time. And so we have seen many of these traditional healers become activists within their network. And so that indicates to us that there is long-term change, because these individuals have become more active in disability rights promotion themselves. But for some of our specific research goals, we don't have clear answers on those. And recently, we've been pivoting because part of this work with traditional healers was recognizing that if instead of treating kids in the community using traditional practices, some of which may not work, some of which might be harmful, but trying to get traditional healers to refer children to health facilities, that we're also asking them to give up income activities. And that's a very challenging thing to do. So Quisel has been working to basically try to integrate traditional healers with the new cadres of community health promoters that are working in communities as a mechanism of getting healthcare closer to people, and that these community health promoters in Kenya are taking on sort of more and more responsibility for identifying healthcare needs and getting people into care. That we were going to start shifting to thinking about the more formal healthcare system and addressing stigma and discrimination within the healthcare system. In the meantime, during the pandemic, Quisel also helped write a local disability rights bill that includes a lot of different factors related to health rights, in addition to education and other sectors. So I'm currently working with them specifically on the health rights piece, but they're doing much broader work in the community. So part of this project too is to help facilitate the implementation of this local law related to extending healthcare throughout the Kilifi County. So we've been doing this project in partnership with local government. The picture here on the slide is with one of our key partners. She's a physical therapist and works at one of the bigger hospitals in Malindi. She also works in the local health department to identify health system gaps and strengths related to care for people with disabilities. And we've been doing this in a variety of ways. We've got a baseline survey going with community health promoters and nurses. We've been continuing our GIS mapping activities. We're developing facility assessment forms to assess accessibility at the different levels of health facilities throughout Kilifi County. And then we're partnering this with Kuhenza's case management app data, which you all might be interested in as well. If this is how they track the kids and families in their network and maintain connection with them over time to make sure that their needs are being met throughout the county. So we're pulling all of this data together to help local government with an implementation plan for carrying out this Kalihi County Disability Rights Act. And one of Kuhenza's main roles in this will be doing sensitization trainings for community health promoters and nurses. So we are in year 2 of this project. We have finished our baseline survey data collection for nurses and community health promoters, which I'll quickly go over with you now. And then I can open it up for Q&A. But the Kuhenza team, our team of data collectors, they try to get a combination of both urban and rural facilities throughout the county. And what we wanted to do was interview as many nurses and community health promoters as we possibly could at these different facilities. On our surveys, we have a lot of questions related to stigma beliefs and also knowledge, just generally about disabilities, but also about specific types of disabilities. We added in some additional questions around microcephaly, because microcephaly cases have been increasing, and also autism as one that is generally not well understood, but trying to get a stronger sense of sort of baseline knowledge around autism as well. So here we had a range of different stigma measures, again, that map on to some of the theory I covered already, trying to get clearly at distinguishing between fear and moral judgment, also concerns around equity and fairness, whether or not people see children with disabilities as deserving of care and concern, looking at in-group, out-group, social distance questions. And then we also added in this area on social role fulfillment. There's been a newer approach to studying stigma that is called the What Matters Most framework. And the idea here is that oftentimes if people are seen as not being able to fulfill valued social roles, that is a source of stigma. That if it's seen that, you know, people are not able to have a family, that they're not able to learn, that they're not able to contribute to their communities, that is also a source of stigma. So we added in some additional questions there due to this newer area of stigma research. So we just got this data back recently, and I have 2 students who are working on it. So it's extremely preliminary. So I'll just cover our sort of like early findings on the stigma questions. Okay, this is like hot off the presses. I just shared this with Kuhenza a couple weeks ago. That we have a sense of which questions are demonstrating highest levels of stigma and which questions less so. So the top 3 questions here were the ones that community health promoters had the highest stigma beliefs on. So here the score of 3 means sort of like most negative beliefs or like worst beliefs, and 1 being less stigmatizing beliefs. So here you can see that the first question about not being terribly concerned about the challenges that people with disabilities face, that there is an agreement with this idea that children with disabilities are punishment for the sins of their parents, and that there is some agreement with the sort of acceptability of giving children with disabilities less food than his or her siblings. And then below are the questions where we had sort of like the lowest stigma scores. With the nurses, we had some interesting differences. Generally speaking, stigma was lower amongst nurses than amongst CHPs, which I think is to be expected a bit due to higher levels of education. We also saw that question that was, you know, seen with like high levels of stigma among CHPs, that children with disabilities are punishments for the sins of their parents, that one most nurses did not agree with at all. So we saw kind of like a reverse on that question amongst these populations of people. But we do see some concerns, especially around, say, fear or consideration for challenges. And in my mind, when I look at this just initially, and again, this is very early, I see this as maybe just discomfort with potentially not having enough interaction or experience in providing care for people with disabilities. I've started looking at the knowledge questions, and the nurses' knowledge is quite high. Both nurses and CHPs, we saw autism coming out as like the least understood condition. So we definitely see some areas for training. But what I see here is that potentially, greater sensitization work will need to be done amongst the community health promoters, and that with the nurses, that maybe some of the training materials will be much more around getting greater experience and exposure to providing care for people with disabilities. So those are just, really early thoughts about some of this baseline data. So we have a lot more work to do in understanding what the baseline surveys are telling us. We also want to do some analyses to see how stigma beliefs affect knowledge. We are planning to present these findings to local government in early June, and to use it as a way of creating trainings for CHPs and nurses. I'll also, be helping Kuhenza design their monitoring evaluation instruments and systems around the trainings that they're going to do. But we're going to use this again to help put together this implementation plan for the Kalihi County Persons with Disabilities Act. So that is just a very quick summary of the work that we've been doing together.